Welcome, everyone. My name is Paige Kennan, and I will be your moderator today for this edition of Can Do MS Webinar Wednesday. Today, we're going to be focusing on the topic of understanding MS disease progression. Before we get started, I want to take a brief moment to thank our sponsors. This year, we have several webinar sponsors, including EMD Serono, Genentech, Sanofi, Viatris, and Zenas Biopharma. Thank you to all. Today, we are joined by two healthcare professionals out of Las Vegas. We have psychologist Lucille Carrier and neurologist Lei Hua. Lucy, Lei, thank you for being here today. And I'm going to pass it off to Lei to get us started.
All right, perfect. Well, thank you for joining us, everyone. We'll kind of just jump right into it and then have some questions at the end. So our learning objectives today is to learn about MS disease progression. We're going to talk about disease-modifying therapies and how that impacts progression. And then we're going to talk about strategies to manage progression. All right, so next slide. So we'll jump back into us. Now, this is the classic definition of MS and the different courses. This is what we call the natural history of MS. So before we had any disease-modifying therapies, when we did large population studies, we always wanted to see what actually happened. And based on our understanding of the disease at that time, we then kind of came up with disease classifications. So this is around 1996, where it was that traditional relapsing remitting, secondary progressive, primary progressive, and then originally a progressive relapsing course. So this is sort of based on what we understood as the natural history of MS. So I'll kind of step you through this diagram. What you have on the bottom is just time. So we're talking about from disease onset, and then you can see the 5, 10, 15 to 30 years. This is just a schematic where most people fall. At the very bottom, you'll see relapses. So these are the clinical relapses that patients would feel and would actually go to the hospital for. So that first relapse, we always just called that initial onset of MS, but to have MS, the first part of it is multiple. So you actually have to have two relapses before we would traditionally call you multiple sclerosis. So you'll see that first relapse, it's what we could consider the clinically isolated syndrome. And then the second relapse would then be where you would have that definition of MS. And because it was a second relapse, the propensity then to have continued relapses was there. So then that became the relapsing MS disease course. And what you can see between like the first relapse or the second relapse is that patients will usually have changes in neurological symptoms, neurological functioning, and then there will be a recovery period where they'll go back to baseline. Sometimes if you don't recover completely from the attack, then you have a new baseline. And you can see that every single time there was a new attack, the baseline would continue to shift and continue to kind of change over time. And then we get to around that 15-year mark where the relapses are less frequent. And instead of having a flat clinical course between relapses, there's actually kind of this slow change. So it's clinical worsening that wasn't really driven by relapse activity. So that's where that idea of relapsing remitting MS and secondary progressive MS came in. It was that clinically apparent change was that there would be accumulation of disability that did not seem to be driven by relapses, meaning that the baseline would change, but it wasn't driven by relapses. So that's kind of that natural history. On the left side of the screen is just our traditional how we measure disability, which was based off of the EDSS score. It's a score that ranges from 0 to 10, 0 being completely normal and healthy, 10 being death. And where we typically measure disability is around 6. And what that means is needing a cane to walk. So there's gradations of it, but the EDSS is really driven by the need to what we could measure on our physical exam, which is your ability to walk. It doesn't really take into account cognitive dysfunction. It doesn't really take into account incoordination or any of the other symptoms that might lead to disability, fatigue being one of the most prevalent ones. So really, when we're talking about this, it's largely driven by physical function. Next. So this is where we really kind of started being able to make the change in MS. So in the current treatment era, remember our first disease modifying for therapy for MS was approved in 1991, and that's been over 30 years. So we've had over 30 years of being able to treat and make an intervention. And what we've really been able to do, or what we had thought, was that blue line, that expected course there, right? So that if we started patients on treatment right when they were diagnosed with with MS, right, that second relapse, and we stopped all future relapses, we would expect a person to be flat that entire time. And then they still might kick in this silent progression period, um, but or sorry, that slow change in disability as that blue line kind of comes up, but that clinical threshold is so much lower that they actually never reach that disability level of needing a cane. So you can kind of see that at the very end of that blue line, even though it starts going up, that ultimate disability level is still only about a 3, which is actually very minimal symptoms. Unfortunately, what we actually saw was that orange line. So even though we stopped relapses, there was this slow accumulation of disability that wasn't particularly driven by relapses, and that patients still continued to decline. Now, they weren't declining as drastically as when they were building up relapses over and over, but there was still this slow, steady decline that's happening. And then that ultimate disability was still higher than what we had expected if we were able to stop everything that was driven by MS, by the inflammation that was actually happening. So um, our definitions of progression has changed, our definition of the clinical courses of MS have changed, and we're no longer talking about relapsing, remitting, converting to secondary progressive because that didn't actually match what was happening once we were able to stop relapses. And so we're not really talking about the classifications of MS of relapsing, remitting, progressive. Our discussion is changing to what are the biological processes that's causing relapses and what are the biological processes that's causing that progression, but that both of these things are occurring from day one. They both occurred very early in the disease course and they continue to build up over time, but that it's not a transition from one course to the next. It's just that both courses are starting from the very beginning and we're able to stop one and the other one we're starting to learn about. Next. So this is sort of kind of that idea that we're talking about. And again, it was just because we were studying from our patients, learning what we were doing from large observational studies and understanding. And that red is what our best understanding of MS was at that time, right? That we would have these waves of inflammation, these immune cells would enter the CNS or the brain and spinal fluid space. They would cause injury to the blood-brain barrier. It would cause lesions that we would see, and that the white matter lesions were much more prevalent than the gray matter lesions. And then we thought that eventually what would happen is that as the inflammation goes away and you start getting into progression, which is in the green box, that progression was driven by a lot of just age-related processes. So age-related neurodegeneration, iron toxicity, vascular comorbidities, and diffuse injury. And what we didn't understand until more recently was that that coral box was actually what was driving that silent progression. So because we were witnessing it with our patients, we really wanted to understand what was driving there. And then our understanding now is that, again, that coral box is actually occurring. That's driving progression. And that's kind of the diffuse injury that we're seeing both in the white matter and the gray matter, the cortical demyelination, the prior lesions, the prior injury that's there. Well, those lesions slowly expand, so they get larger over time. And then compartmentalized inflammation. What that means is inflammation within the brain space itself, within the CNS itself. Undergoes slow inflammation, and our disease modifying therapies don't target that because they can't cross the blood-brain barrier in doing this. And all along the bottom, age and disease duration kind of go hand in hand. The longer that you have your disease, the older you are, and it's hard to separate. But the highlight of this slide is to really recognize is that the progressive symptoms or the progressive biological process we see occur from day one. It's that the inflammation goes away and the aging increases, but those progressive processes are always there, and the contribution of each process changes with age and disease duration, rather than that it's a change in the clinical course itself. Next. So when we're talking about progression, and I mentioned that age and disability duration kind of come hand in hand, well, when we're talking about aging, that has a really huge driver of progression in MS. And this is a slide where we're really just highlighting all the biological changes that typically occur with aging, but that are really critical for people with MS. So the first corner where you can, the first upper left corner where you see A, we're talking about what we call telomere attrition. If you're unaware, what that means is in your DNA, there's all these extra base pairs at the end of it. And the older you are, those extra base pairs drop off and they kind of become shorter and shorter. And that's a way for us to measure someone's age biologically. And what I mean is that there is their chronological age, which is everything that we always talk about, right? That's defined as when you're born and then measuring time from there. But biological age is actually the age of your cells, and each of your cells has a different age. So you can have a different biological age for your brain cells, a different biological age for your immune cells, different biological age for other things. And that is influenced by genetics as well as environment. So for example, if you smoke, well, you cause more inflammation to your lungs, and then your lung cells might appear older than they would actually from biological age. If you have a disease such as MS, your brain age might appear much older than your actual chronological age. But for us to measure that, we kind of base it off of then these telomere shortenings. As that's happening, as your cells age, they start losing function and they start creating more inflammation, which is kind of what you see in that box below, is that all of these different cells, depending on everywhere in the body, as they get older, they start not functioning as well and they cause more inflammation. The box at the bottom left, the mitochondria, your mitochondria are your uh, organelles inside your cells that's really responsible for utilizing energy and dealing with stress. And as the mitochondria gets older, the ability to deal with stress reduces, the ability to use energy efficiently also reduces. So we kind of have that overlaying everything that we're seeing in terms of patients. With reproductive aging, what we're really getting into is the hormonal changes that happens over time. It's really obvious when we're talking about how MS disease impacts women, because we see a huge spike in MS with puberty, and then as menopause hits, we see a significant switch to maybe more of that apparent progression because of it parallels those changes in the uh, 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 menstruation cycle of females in that reproductive cycle. For men, the link is a little bit harder to measure. We do see that low testosterone is associated with a higher risk for MS, but it doesn't track the disease course the same way as we seeing estrogen and progesterone levels track for females. There's also influences in the gut. So as you get older, your gut becomes leakier and allows more inflammation to occur. And again, that kind of leads to overall inflammation that we see. And all of these impacts then the inflammation that we're seeing, they're just changing how your body reacts to different aging processes, different inflammation processes, and that's sort of then getting to all the changes that we see within the brain itself. Uh, the last thing that we'll talk about is just that comorbidities, and that's that what's in the right-hand corner. And what I usually tell my patients is that MS doesn't protect you from life. So if you have cardiovascular disease and other things that's happening, well, that also contributes to the aging process that we're seeing, and having to separate that becomes pretty complicated. But MS itself is a very complicated disease, and we're just trying to sort out everything. Next. So on this slide is really just a couple of highlights. Depending on what you are hearing in the research literature, depending on how well you are abreast of the MS updates, there might be some things that you're hearing. So this slide kind of maybe just brings it all together. What you're really seeing is on the left is what happens early in the disease when it's really more of that red box where it's the focal inflammation. And then what you're seeing on the right is a lot more of the neurodegeneration processes that we're seeing that's happening there. So if we highlight one, which is kind of the big lesion that you see on the left, when that occurs, what we're seeing is that active lesion that's forming because your immune cells are attacking your brain and spinal cord. And if we capture it at the right time, we see gadolinium enhancement. So we see that if you get an MRI study and we say, oh, it's enhancing lesion, that's what we're talking about. Now, if you kind of follow that same lesion and you kind of follow what happens to that lesion, and then we kind of see that schematic on the right side, well, you no longer have that focal inflammation. You no longer have that GAD enhancing lesion, but what you get more is chronic inflammation. So right at the edge of that lesion, you're getting more inflammation, and that causes that lesion to slowly expand. So that's what we're talking about when we're saying slowly expanding lesions, is that those lesions slowly get bigger and bigger because right at the edge of that lesion, there's inflammation. There's a couple of different ways that we can measure it. So if you're paying attention to the literature, and what we're calling recently is PEARLS, that really just stands for a parametric rim enhancing lesion. So that's kind of what we're measuring it. Now, all of this, what you can see on the right and left, is how we measure different inflammation. So MRIs are the classic. It gives us that inflammation. There's neurofilament testing, which is also just another measure of inflammation. We can see remyelination early on in the disease, and you can kind of see what that looks like on higher quality MRI scans. And then we can kind of measure the evoked potentials in your optic nerve. So if you've ever had a VEP, that's what we're measuring, is how well your axons send signals. And then where the disease is moving to is what we're looking for on the right side of the screen is our higher quality MRIs. What we're really doing, the active research, is that we want to be able to better measure some of these processes so that we can understand what's actually happening, and then we can actually test and look for treatment. Next slide. So if we put it all together, what's actually happening? So a couple of different things that I'll kind of step you through on this slide. On the very bottom is then because kind of sort of what we understand to be MS, right? There is some initial underlying genetic processes, predisposition to MS, and then you get exposed to various risk factors, environmental risk factors, and that turns on the disease, and then you have that biological disease onset. And then as that biological disease onset, that inflammation is occurring, there's this kind of prodromal period where you're not completely normal, and yet you feel off, but you haven't yet had your first attack yet, right? And then you get to the clinical presentation, and then the clinical course and the evolutions there. What you see at the very bottom in blue, that early in the disease, you have that really a lot of reserve, and repair mechanisms are great, but that declines over time. And then that's the process that we call biological aging. Where everybody with MS feels, though, is in that purple box. That's that clinical expression. That's what people are actually feeling. And then when we're looking to what we're trying to do as researchers is truly understanding what's happening in that pink box. What are the biological what's in that coral box? What's actually happening? That's the inflammation, the demyelination, the axonal degeneration. That pink box allows us to measure those processes to really get there. But all of this kind of comes together into kind of that purple box. So it's a complicated process, but we're really trying to understand everything that kind of goes into it. And sometimes when maybe you're talking to your doctors or talking to other people, you might get different answers because, again, it's such a broad thing that we're always trying to impact and influence. But if we just focus on one thing, we always miss the whole picture. So we always want to kind of take a step back. And while we kind of really discuss this one piece, we want to get to everything. What Dr. Carrier will mention is really kind of in that blue box to the left later, is that what can we do about it? And you can just see that everything that you do, your biological sex, the infections you have, your genetics, your socioeconomic stuff, your microbiome, what you eat, diet, exercise, comorbidities, all of that influence these things. So when we're talking about how we treat MS, not only is there a role for disease modifying therapies, but there's a lot you can still do that you can actually influence. And again, Dr. Carey will really get into that in the second half of the talk. Next slide. So what do I want to talk about here? So we originally talked about understanding the biology, and we have that red box where I talked about that inflammation, which is what we kind of stepped through all those slides, is the immune cells attacking the brain and spinal cord. And then we said that there's all these age-related changes in that green box that just happens to everybody with MS, or everybody in the world, regardless of whether or not they have MS, but it has a special impact for people with MS. And the coral box is because we've had disease modifying therapies that have really shut down inflammation, shut down relapses, but we still saw that silent progression. That's where a lot of the MS focus energy has been over the past several years, is really better understanding that and better so that we can really attack then that silent progression. Now, our current disease modifying therapies don't address anything in that coral box. But because we have better understand that coral box, next page, um, we are better able to measure it. That actually is where we are currently, and it's why it's such an exciting time in MS, is that we actually now have therapies that can target things in that coral box. So again, the better we understand the disease, we had our prediction we thought would happen. Although we did a lot for disability, we still weren't able to target that silent progression, but you had to unmask it, right? By stopping relapses, we were then able to unmask that silent progression. And then we were able to target that silent progression because we understood what was happening biologically. And then by understanding it biologically, we've been able to develop new treatments. So what all our new wave of therapies in terms of talking about how we help progression is really going to be starting to talk about microglia activation, really start talking about that CNS compartmentalized inflammation, developing therapies that can cross the blood-brain barrier and really kind of get to that rim of that lesion as well. And so all of that is just really exciting. We're hoping by the end of the year we'll have our first drug that really just is approved that attacks purple, but we have several drugs in the pipeline that will also be continuing to increase our options for our patients in that pink area. Lastly, I do want to just touch on that green box. So that's kind of aging itself. And that's also something that we're also targeting and looking at. So the next slide. Um, in that last green box, this is kind of that many targets of neuroprotection and the heterogeneity that I really just want to highlight. Now, this looks complicated and looks complicated by design. And part of that is that what I want everybody with MS to understand is that you're all snowflakes. Not any one person's MS looks like someone else's. And that's because what causes the progression in one person might be a combination of, like, 1, 2, and 3 on this slide. And what might cause progression in someone else might be more of like 4, 5, and 6. And so your progression looks different and the treatment and targets are different. So we certainly want to better measure this and better understand. And we're kind of getting there. But again, just understanding here, for me, I look at this slide and it just gives me hope, because it's like, wow, we've got so many opportunities, so many targets to really target this. What we really need is better understanding and better research so that we can then start to individualize care. So in this person, if I can measure a blood test and say, hey, I know that your progression is due to 1, 2, and 7, this is the drug for you. If your progression is due to 4, 5, and 8, I can get this for you. And that's kind of where we're going. We're just not there yet. But I think there's a lot of hope for MS. I think there's a lot of opportunity for intervention. I'm really happy that we're slowly kind of chipping away of all the different biological process that's happening. But I think it's kind of a great time to be where we're at, because we're kind of getting there and we're trying to do a lot of different things. Next slide. So I will definitely happily pass it on to Dr. Carrier to kind of really get through how do we navigate MS progression.
Right. All right. Thank you, Dr. Hua. I really want to kind of take this, a little higher level, right? We just went through, a lot of detail, a lot of really nice, I think, explanation of these biological processes that are driving what we see with regard to relapses and to, just general disability. But when we kind of step back and put all this together, right, we're trying to appreciate that in the context of progression, your journeys are all very different. As Dr. Hu has said, right, your snowflakes, right, your disease experiences are all so different. And the way we understand disease progression is really in a similar light. And so, we're still learning, right? As Dr. Hu was mentioning with some of those really complicated infographics of how we measure this and how we try to kind of delay it. But what we want to kind of step back and think about is just, how do we navigate the uncertainty with all of this progression? I was watching you all in the chat and kind of what it was like to sit with even all of this information tonight through this webinar. And it has an emotional impact. And so we're going to talk a little bit more about that. All right, next slide, Paige. So I want to kind of think about how we're all living with this uncertainty. That is the uncertainty of biological aging, of your MS disease progression. And this is certainly one topic that people living with MS know and know so intimately. It's probably one of the most challenging aspects in living with this disease. Regardless of kind of how many years you've been living with symptoms and your diagnosis, and that's I don't know what's around the corner. I don't know what next year may hold, let alone next month sometimes. And so living with a neurodegenerative disease as MS certainly has those unknowns, right? What symptoms am I going to have? As you're meeting with your doctors and all your clinical visits, trying to decide on your disease modifying therapy, engaging in that shared decision making, you're trying to figure out what's going to work for you and what is going to best address those, I think, your individual experience with your disease, your symptoms. How do you have a quality of life? What does that look like while you're navigating these symptoms? Thinking about the different roles you may have in your life, whether it's parenting, working, just being present, being a community member. And of course, taking this and kind of pulling it together, really thinking about how do I know if my disease is progressing? I've been an MS psychologist for over a decade. And so just looking tonight, along with you all, listening to Dr. Hua and looking at all of those areas of diversity and kind of, I think, ways in which your disease can look different, it's really quite striking. And so, again, kind of thinking about that is a lot to take in. All right, Paige, next slide. So I think this goes without saying, but I think we do have to recognize, right, the emotional toll that, you can experience when you're trying to navigate that uncertainty. There's such, I think, anxiety and worry and even hypervigilance, right? As you are trying to understand your disease, particularly in those early years, you're kind of listening and being kind of mindful of these new symptoms that may be emerging. And what does this mean? Anecdotally, right, patients will say, I'm not sure, does this mean my disease is progressing? Is this just a symptom? I don't know. And so it's so fraught with worry, this loss of control. What's happening in my body? How do I even plan for what's coming up in life next? There's these losses that are happening before even really the deficits may be hitting you day to day, or the challenges you may be experiencing. Sometimes it can throw us into a state of helplessness. I'm just not sure where I can enact control so that life doesn't feel so chaotic and though it's spinning around me. There can sometimes be a sense of isolation. Maybe you're pulling back from life, different roles, responsibilities, worried about, I don't know where my symptoms might be. I don't know how I may be functioning. Can I walk appropriately or, maintain the stamina I need to be present? And of course, with these symptoms, right, the ebbs and flows with the variabilities, it can sometimes affect your sense of self, who you are, as you're navigating not only the uncertainty, but how you're kind of navigating and managing those symptoms that are also affecting your life. It can kind of feel like you're in this waiting game sometimes, which can really complicate your planning and short-term, long-term. This can be really difficult. All right, next slide. So I like to kind of think about this oftentimes when I'm with my own patients and we're talking about, of course, those day-to-day symptoms, right? I'm really struggling with my balance, with my gait. Maybe it's bowel and bladder symptoms. Maybe I'm having changes in my thinking and my mood, right? We're kind of navigating what we're doing. How are we putting into kind of in action these skills, right, to minimize the impact on life. And we also have to recognize that uncertainty that you're living with, right, about the unknown and what's around the corner. And so it really does feel like you're kind of fighting MS almost on two fronts. And I think sometimes it doesn't quite, I think, get the recognition that it needs. And it's an important piece to this. So, how do we make sense of this? When we think about uncertainty, right, in our lives, we often think about we are so hardwired that we feel discomfort when we don't quite know the outcome of things. And the more we're able to perceive the outcomes, right, what's around the corner, the more we have, right, a sense of control. I can plan and I can kind of put into appropriate resources to kind of confront what's in front of me, kind of hopefully reduces those negative outcomes. But when we don't know what's around the corner because our body is just, well, a little unpredictable, it can be perceived as threatening. It's dangerous. It doesn't feel good. So we're going to try and put into place control wherever we can. Unfortunately, our brains can kind of engage in these mental shortcuts. That is, it can lead us to kind of think in ways that maybe aren't always accurate, or maybe we're not considering all the data. And so we can make mistakes in our decision making, sometimes even in our judgment, without quite realizing it. We also have to recognize that each of us, probably no surprise, we experience and kind of tolerate uncertainty in a lot of different ways. And we kind of think about this more from a personality perspective, right? Those people in life who can kind of just go with the flow. And then there's those of us that like to have a lot of control and a lot of certainty with what's around the corner. And when we step back and think about our own physical health, this has huge implications, right? Your whole life has been kind of planning around at times your health. And we really want to, I think, appreciate where uncertainty really plays a role. All right. Next slide, page. So I often like to think about, right, our ability to sit with this uncertainty, right? How's my disease progressing? How am I managing this? Kind of on a spectrum. This is really kind of a continuum, if you will. You've got the folks kind of on the low end, right, as I mentioned, who can kind of go with the flow. They're okay with ambiguity, right? Sitting with the doctor, not quite getting that kind of black and white answers that they're looking for. They can be a bit more flexible. We tend to see these individuals able to use a bit more of like healthier coping styles. But then when we have those folks kind of on the far end, those who are really uncomfortable at the idea of this uncertainty, this is really when we start to get more worried. We know from research and even research into those living with MS and understanding kind of how they can tolerate uncertainty. Unfortunately, we know that those who have a higher tendency to feel uncomfortable with this do tend to have a lower quality of life. We do tend to see lower measures of overall well-being. And we really kind of think about those individuals as just kind of being a bit more at risk for worse outcomes. And although this isn't diagnostic or anything of that sort, I think it does kind of give us a good sense, though, of kind of where you fall, thinking about yourself. Because unfortunately, the higher we are in this kind of personality trait, we tend to have higher rates of anxiety and worry, especially about your health. Those individuals, right, who are really hypervigilant. We tend to see more engagement in some of these unhealthier coping strategies. You know what? I'm just going to avoid it. I don't want to make a decision. Maybe you are trying to kind of get a lot of reassurance, maybe overly so. You may engage in some other types of unhealthy behaviors. So it's just something we really want you to kind of think about, kind of get in a sense of where you fall on this, right? Where is your personality? And where has this kind of shifted now in the context of living with MS? Whether you're a few years into this, or maybe you're a few decades into this, where have you seen perhaps some changes in this too? All right. So I want to link back again to your journey with MS, right? And kind of thinking about where do your biggest uncertainties lie right now as it relates to your health? Are you thinking about the functional pieces? Are you thinking about, again, the progression? What is this looking like as I'm, getting older? Where is aging coming into this? And how do you cope with this? Are you one that you engage in a lot of worry? For some people, worrying is almost kind of a way to exert control. Let me think about all the worst possible outcomes, and then I'm going to plan around it. But boy, doesn't that have an enormous impact on your health, right? Physiologically, psychologically, and to those around you. Do you ignore it? Are you kind of like an ostrich? You kind of stick your head in the sand and just kind of, well, let it just kind of pass around me? Do you face it head on, right? Do you kind of get more assertive and try to kind of, take some of that control? And so I think this is an important piece to understand, again, where your personality is and where kind of we can start to make some of these changes. All right, so how do we start to tackle this? So this is really where I kind of pull on what we know from the available literature, and that's really about how do we kind of stay present, right? How do we really try to focus on what matters to you? I've seen some of this in the chat already tonight, and it's just I think a great sign of how we really start to kind of focus and anchor ourselves. This is something where you probably have heard a little bit about mindfulness, meditation. I have definitely seen some comments in the chat, but this is sometimes, a practice that can be helpful, particularly in anchoring us when those thoughts, those emotions just become overcharged. You're leaving the neurology visit, maybe you didn't get the best update, or that update wasn't really clear. It wasn't really what you were looking for. You're not sure how to make sense of it. How does that apply to me? And it can be overwhelming, right? Your body just becomes overly activated. And so, what we're trying to do, right, is really kind of notice those thoughts, notice what you're feeling in your body. We're trying to withhold judgment or try to adjust or change those thoughts, but really kind of going back to kind of what's simple, right? Focusing on your breath, your sounds, your body scans, really just to kind of anchor yourself in those moments and not allow for your mind and those thoughts to kind of put you too far into the future. It's really about kind of paying attention on purpose. Again, noticing what's around you. And so this can sometimes be helpful to reduce some of those unhelpful worries. Again, that can kind of just become overwhelming. And over time, this is a skill with practice that can really be quite helpful. And it's something we can build on. For a lot of people, this just doesn't come quite natural, but it's something that just like when we go to the gym and we're trying to kind of build up our strength and our muscles, this is also another way I think about this of kind of building some of these mindful and meditative practices that have lifelong benefit when you're living with such uncertainty that's kind of surrounding you. There are certain forms of psychotherapy that when you connect with a mental health therapist, that they can really individualize this and go into much more depth for this. So that's something to kind of consider as well. And then, yes, as I mentioned, the mental health support I think can be helpful. Again, with how do I stay focused? How do I stay present? How do I, again, build a life around what matters to me? um, Even in right the context of living with this uncertain neurodegenerative disease, right? How again do I kind of try to live my life as full as I want in spite of these uncertainties? That I may plan a lunch with a friend next week, and I might wake up and feel like I can't quite move my legs today. This just doesn't feel like the best day, right? How do I kind of plan for that? Plan those contingencies because we want you engaging in those passions in life, those pursuits, the things that really matter to you. Another aspect of kind of how we manage and navigate uncertainty really relates to demystifying and thinking about what you know about MS and increasing your knowledge and your planning as well. Sometimes uncertainties can really be rooted in maybe misunderstandings about the disease process, understanding symptoms, how they emerge, what to make sense of them as. And so your MS education, your knowledge can be really powerful sometimes in dispelling that. I find this is often the case really early on, but also too, we want to realize it has a role even later on as we've been living with this for many decades. So this is really where linking back to your MS team can be really, really effective to again bring these questions, bring these research, that you're doing, trying to understand these questions you guys got in the chat. They're great. Bringing that in so that you can dispel some of that, so you don't sit with that uncertainty and it just kind of runs afoul. This is, as I mentioned, really where we start to kind of, again, we get practical. We talk about backup plans. We really try to be as flexible as we can with that uncertainty of where life may be leading me, where these symptoms and where my body is kind of, presenting some challenges, really to kind of help you feel more at ease. I got to give a shout out here to our Can Do MS library, where you have a lot of different webinars and different programs that can deep dive more into these certain symptoms and functional aspects to really kind of, again, help better understand this and how it applies to you. All right. And this is, of course, where we come to is really understanding what you have control over, right? There were so many aspects to those different infographics that Dr. Hua was showing us where we're not exactly affecting protein expression or some of the axonal degeneration, right? But what we know from research, decades of research, is where we can make a difference to hopefully reduce some of the impact that MS is having on our day-to-day life and the overall disease trajectory. This is really where we come back to those healthy habits, routines, right? This is really where we are trying to think about how we're eating for our wellness, moving with purpose, right? Prioritizing our sleep, our stress management, kind of building our resilience and following those MS care plans, right, that we're developing, with your provider, with your MS team, staying on top of your appointments. And, while it can be really challenging, I think putting to practice a lot of these health behaviors and in these changes, this is really where we do recognize that behavior change is tough. Being consistent is tough. I recognize that. This is really a lot of what I do in my own practice, right? Life is changing around you. Your disease is changing. What worked 5 years ago may not work so well now. And so this is really where we recognize that change is happening, but connecting with other, healthcare team members, your rehab providers, mental health providers can sometimes give you just that added structure, accountability, support, guidance, whatever might be there to make those meaningful changes, ones that really I think are important for you. And of course, right, thinking about your support partners, building that circle around you, whether that's your family, your chosen family, friends, whomever, connection groups, to really kind of help, champion, encourage those changes that you're making.
Awesome. Thank you so much, Lucy. All right, and Lay will be joining us back here in a second too for a Q&A. Lucy, since you ended with talking about a support system, can we just take a couple minutes to talk about how progression in MS can affect care partners, people who love those that are living with MS? Just kind of I know this could be a whole topic, but a brief conversation about how this affects care partners.
Yeah, I think absolutely. I think as many of you, right, are trying to make sense sometimes of the progression, I think your care partners are doubly experiencing this and maybe even, feeling ill-equipped to know when to step in, right? Is it more practical aspects that, they're wondering where they can help? Is it the emotional impact that they're experiencing, right? What are their fears currently? What are their fears for the future? I often find with care partners, it's, how do I be the best partner? What is it that I need? And I think it always starts with a conversation, asking where you can be most helpful.
Awesome. Thank you, Lucy. I am going to put a shameless plug in for another program that we have here at Can Do. I put the link to it in the chat. We do have meetups specifically for care partners. That can be a spouse or a partner. It can be an adult child, a parent caring for somebody with MS, a neighbor, anyone who cares for you. If you are living with MS, and cares about you emotionally, they don't need to be physically taking care of you either. So we'd love to have folks join that. We also have care partner resources in that resource library that I shared as well. All right, so we're going to get into a lot of questions. We had a ton of them, so I'll try to rapid fire as many as we can off in the next 12 minutes. All right, so we had quite a few questions about MRIs. So Lei, I'm looking at you. Um, we had several questions about having stable MRIs, but still experiencing the feeling of progression. Can you talk to that a little bit?
Yeah, absolutely. And I wanted to save time for questions because this is kind of getting the more interesting part of what we're doing. So I don't know. Can you pull up some of my slides again?
Absolutely. Yeah. Which slide would you like,
If
Lei?
you pull up let's do slide 10 for me.
Let's take a look here.
So we get into what we talk about standard MRIs or conventional MRIs, and then advanced MRIs and the specialized techniques that we're looking at. So the standard MRI that you would get, that I would order for my patients, really only measures the inflammation that's happening peripherally. So what that means is your immune system having active attacks on your brain and spinal cord, which is sort of that left picture that we're showing here. And then the MRI in the top corner. So you have a lesion because of a new attack on your immune cells. We'll see it as a lesion on an MRI. And if we just happen to capture that acute inflammation, we'll see it as an enhancing lesion. But let's say you have an MRI like 6 months after your relapse, well, the enhancement won't be there anymore. But if we do frequent enough MRIs, like every year, we'll still be able to tell that there was a new lesion compared to your prior MRI. But that all the MRI measures are relapses. It doesn't measure that progression. It doesn't measure that silent progression that we're seeing. So it is very often that I have patients come in and saying, I feel progression. And I say, I get it. And then we'll do the MRI, or they'll say, I'm having a relapse. I was like, no, you're not having a relapse. You're having progression. The MRI shows that you're stable. And they're like, well, then why do I feel bad? I was like, because the MRI is not measuring progression, right? And that's the basics of it. The MRI that you can get typically will measure the focal inflammation, but it doesn't measure a lot of those biological processes that I spent time talking about earlier. We need higher quality MRIs. We need specialized sequences. Right now, they're pretty difficult to standardize. And so outside of research studies, they're not something that's regularly obtained. But what I was alluding to, all the MRIs that we're doing on the right side of the screen are all those specialized research. So we know that's happening. We just can't measure it when you kind of go to a doctor on a regular basis. But when we do MRIs over time, specialized, we can see those lesions starting to get larger. That's the slowly expanding lesions, or the smoldering lesions that people have talked about in the past. Again, just different ways to talk about it. But all those things that you're reading about is specialized research techniques, but it's not something that we can use on a regular routine basis for patients.
Awesome. You actually answered three questions in that
Oh,
answer.
fantastic.
Thank you for getting into that. Let's jump to talking to some neurologists. This is both for Yule and Lucy. Some folks have expressed some concern as they've been aging. When they talk to their neurologist, some neurologists kind of, for lack of a better term, blow them off and say, all of these symptoms or issues are due to your aging, and not due to your MS without doing testing. Is that something that they should accept? Is it something that they should advocate for themselves? What are your thoughts on that?
So this is what I would just classify that this is actually a really hot topic in MS. And it's an area of interest of mine. It's sort of something that I've always been focused on, is just the aging population, because they're not getting enough attention. As the peak prevalence of MS is shifting to older ages, older patients now make up the bulk of people with MS. So we certainly need to have a better understanding of it. But as with research, as is everything, it's hard for the people who are the MS experts, we're just finally disseminating to MS specialists. So the people within the MS specialists who've been really interested in aging, like I've been interested in it for 12 years, it really has only been popular for the last like maybe 4 or 5, right? So it's spreading, but then to get to the general neurologist is just going to take more time. I would say it is actually really critical to think of aging and how that plays, to kind of discuss what you can kind of do for it. This is where Dr. Carrier's talk is really great because, again, there's a lot of things you can personally do to kind of slow down aging. Exercise is a really big thing. Eating well, all those things matters because those are things you can do to slow down aging while the science catches up, while the research. It is a very broad field. And again, that's the complexity of it, is trying to figure out what we know about aging broadly and how we can then take it to people with MS. But absolutely, I would say that if you're not getting the answers you need, you're getting dismissed, um, uh, seeing an MS specialist is key, is critical. And then if you're not getting answers, you might need to be kind of more at a specialized MS center where they have more time to discuss with you. There's several clinics that are talking about how we can then better serve our patients with our older patients with MS. We're just not quite there yet, but that infrastructure is something that's kind of building.
That's great. Lucy, do you have any extra tips or anything on how to advocate for yourself at your doctor's office?
Yeah, I think this comes back to, again, that assertiveness, right? Of really bringing in what's most meaningful, what's on your mind to those doctor's visits. Writing those lists out, as simple as it sounds, can be powerful to really kind of prioritize, that you get those questions hopefully answered. But, as Dr. Hoa mentioned, I think trying to, find those providers at those specialized MS centers can be really powerful.
That's great. Thank you both. So I've seen this question a lot in different ways, um, and kind of a two-part question. So one, a lot of folks have either been told by their neurologist or have just heard from various things that they've been a part of, that they should stop their DMTs at a certain age. And then with that, some folks have also heard that MS burns out or drops off when they reach a certain age. Blake, can you talk about that a little bit?
I'll talk about the second question first. So the burnout phenomenon is, I don't really like it. It's not a term that I use. I think where it was traditionally saying is that idea that that focal inflammation decreases. So as you get older, those immune attacks stop, right? So your immune cells get older. That's the senescence phenomenon that we're talking about. As your immune cells get older, their ability to fight off infections decreases, but their also ability to cause lesions decreases. So when people talk about burning out, I think that's what they're referring to. It's just not something that I use because I don't think those terms accurately reflect what's actually happening. And then as that's happening, it's not new injuries that you're accumulating, it's kind of your old injuries that are causing more problems. So as people get older, if you're not having relapses and you're not having the focal inflammation and our therapies are targeting relapses, well, it might not match. So the treatment has to match what's actually happening biologically. So that's the idea of why we're stopping medications, because if you're no longer having relapses and the medication's meant to stop relapses, what are we stopping? Right? My only caveat with that is everybody's MS is slightly different. So I don't think there's a set age that everyone has to stop, but there's a set age where the frequency of relapses generally occur less. So you can always try, you can always stop it, see if you still need it or not, and then readdress it and revisit it. So on a very individual level, it has to be kind of be that individual decision, but I will generally talk to my older patients with it who've been stable to say, hey, are you wanting to stop medication or not? Right. And then if we stop medication, you're not done, but we're stopping and then we're monitoring to see if you still need it or not. So hopefully that answers that question. Did I answer it? I think I did.
Yes, you did. I just want to make this clear because it does come across in some of our other programs too. You said once you stop your DMT, if that's the choice between you and your healthcare professionals, um, you should continue to see your MS specialists ongoing, correct?
Yeah, because again, I wish I had a crystal ball, but I don't. So short of that, we can only, again, just there's always the bulk of people, this is what we expect. And then on an individual basis, we have to see if you fall into that group or not. So I will stop medications on patients, but I still need to follow them to ensure that we made the right decision. So if you stop seeing us, we can't ensure that you're actually okay off of medications. There's also other things we can do. So, right, there's physical therapy we can make referrals to. We can kind of treat some of your other symptoms that's kind of helping. We can kind of refer you to specialists like what we do here, to Dr. Carrier, to really help with navigating the MS progression from other things. So there's all sorts of other things we can do. You're not just seeing me because you need a medication. You're seeing me because you need your MS to be cared for. So you should still be seeing your doctor because there's still other things we can do for you, even if it's not a disease-modifying therapy itself.
A wonderful answer. Thank you. Before we finish, I want to ask Lucy one more question about the connection between depression and MS disease progression. Is there a connection? How do we look at that?
Hmm. I often talk about with my patients, right, that depression can often either be a symptom of the disease, or it can be in reaction to, right, those changes going on in life, or more often than not, a combination of the two. I think sometimes it can be hard to know. What I really kind of focus on is, right, the treatment of it, because we know what can happen if we don't treat it and the effect that it can have on other aspects of life. Maybe you stop going to your rehab visits. Maybe you're not taking your medications as consistently as you should be. And so it just has such enormous downstream effects into the trajectory of the disease, where we really want to ensure that we're treating it just as we are any of those other symptoms of MS.
Thank you so much. We had quite a few comments about struggling with mental health and things, and I know that it's a very important topic at all of our programs. So we will,
Paige, can I
yeah,
make one more comment if I can
of
make a
course.
plug?
Yeah,
So, one of those things we're talking about is kind of as patients what you can do about your disease, and as specialists, what we really need is help and partnerships from our patients. So participation in research studies. The other reason to kind of go to an MS specialist is as we're building up registries and understanding older patients, we need patients to come to their doctor's office because a lot of our research, if you stop coming to us, we don't have the data needed to kind of make some of the decisions that we want to make. So certainly continue seeing to contributing to research, participate whenever you can, because that's how we learn. Like we learn from our patients and we can only learn and then continue to be better by doing so. The newer therapies, like I mentioned, like we are understanding from our patients. We are then understanding the biology when we test hypotheses and we kind of hit one mark, but we miss another mark. We continue to do research so that we can better learn from our patients. And so contributing to that body of knowledge is actually very helpful for us, very helpful for future generations, so that we can kind of do what we want for our patients. Again, it's actually meant to be, it's actually really a positive time in MS. We have newer therapies that are on the horizon to be approved for progression. So I think that will change how our discussion becomes. So it won't really be a stopping medications, it's changing to the right medication that matches your underlying disease. So
that was a great way to end it. Thank you, Lay. So before we sign off completely for the night, I just want to point everybody towards our social media pages. We are on TikTok, X, Facebook, and Instagram. Lots of different news and resources come out in our on our social media pages, so please join us there if you have not followed us already. We want to take a quick moment to thank all of our sponsors for the webinar series once again. Thank you to all of our sponsors. Lucy, Lay, thank you both so much for all the wonderful information that you shared tonight. For everyone who attended tonight's session, thank you for being here. I hope everyone has a great evening.